So we can move forward to the next slide. Thank you. So I'll give you a brief overview of our patient population, their dysphagia concerns and medication profiles. And then I'll pass the presentation over to Janice, who will give us a detailed case study of an effective medication on swallowing. Next slide. So our patient population, the description is taken from a convenient sample of 32 community dwelling adults with developmental disabilities. You can see from this slide that they are a very diverse population. And I think the thing to remember that's most important about them is that they rely on someone else to communicate their healthcare needs and their quality of life needs. There are many reasons that people may be referred to our dysphagia consultation service, and you can see this the breakdown of reasons for referral here. Next slide. So what I did when I looked at our patient population is the first thing was to look at the different types of psychotropic drugs that are administered to our clientele. And we can see from this slide that for 32 people, there were 42 prescriptions for psychotropic medications, comprising of 18 distinctly different compounds with one enantiomer. I also looked at the antileptic drugs prescribed to our clients, and we see here that for 32 people, there were a total of 21 prescriptions for anti-epileptic drugs, with 10 distinct compounds represented. The third way that I looked at our patient, in terms of the anti-epileptic drugs, I also looked at what kind of information the caregivers had in their files about whether or not people actually had a history of a seizure disorder or not. So recognizing that the caregivers may not have the complete medical file, but this is based on what information the caregivers did have. And we see 24 people had no record of having any seizure disorder. And one person in particular really stood out to me, and that is the person who had prescriptions for 4 different anti-epileptic drugs, but the caregiver had no record of any seizure disorder. So we're actually going to come back to that person a little bit later in the presentation. Next slide. The third way that I looked at our patients' medications was to look at the total number of prescription drugs for these patients. And I included medications, anything that would require a prescription, including if they had had a PRN prescribed to them, a PRN for a psychotropic drug. And we see that nearly half of our patients have 5 or more prescription medications administered every day. And I'm going to spend a little bit of time talking about 2 people who had a high number of prescription medications. So those 2 people that really drew my attention, the first person is case number 2 in our cohort. And we can see here the types of medications that she's been prescribed, what her presenting diagnoses were, and her other problems of irritability, aggression, physical decline, and problems with what the caregivers described as catatonic episodes with body rigidity that resulted in dehydration. And we can see from the anticholinergic burden calculator that she was at high risk for anticholinergic effects. The other case that was quite striking is case number 13, who was referred because of reduced appetite, coughing during meals, and her lethargy was so profound that it was impacting her ability to eat. And we see here that she also had other problems such as hallucinations, and maybe not surprising given the types of medications that she was prescribed and her anticholinergic burden. So I wondered if our sample population was unusual, and I don't think it is, because there's a lot of literature. Here's just a couple of examples of the types of problems that people with developmental disabilities experience in terms of prescription medications. And there's more references at the end of the presentation if you would like to read further about that. Next slide. So I'm going to pass the case over to Janice, and just so that you know, the person that we're speaking about next is not part of our 32-person cohort, but it is someone who does fit into this general population. So I'll pass it over to Janice now.
Great. Thanks, Beth. And hello, everybody. So I wanted to present on a person that I was involved with and still have involvement with, but this actually was a number of years ago, but I thought it was a very interesting one in terms of medication. So I've called this hard to swallow because that sort of is the topic that we're talking about today. So I'm going to introduce Jenny, who's a very lovely young lady. You can see from, as Bev mentioned, we work with people who have developmental conditions, and I've listed sort of her range of different diagnoses here. I also put in here a little bit about her medical history, just because there was sort of a little bit of a pattern that came out of this. So she certainly had some pneumonias, and a very severe one in 2006. Then seems to sort of stabilize through 2010 to 2017, having some pneumonias, but basically was treated with antibiotics. And then around 2017, she started to have more difficulties, falls, head lacerations. There was a lot of vomiting. A number of issues were going on with her. And so that was when a colleague of mine got involved. But to give you a little bit of background, up until her mid-teens, she was living with family, and reportedly from the family was not on any medications. But into the mid to late teens, there was a need to transition from living with family to sort of an alternate situation. And one of the challenges that they had were that there were significant behavioral issues, many self-injurious behaviors, but also some aggression, which of course was problematic because of injury to staff. So Mom had shared with me that the longstanding family physician had said, you know, Sally, being close to Jenny is like putting your hand too close to a fan. So I think that gave us an indication of the kinds of very challenging behaviors that were out there. So tetrabenazine was suggested by the family as a trial to help sort of address some of this. Initially, it was only a PR medication. And some of you may not be as familiar with that particular medication. It is an older medication. And again, I'm not an expert on medications, but the readings I had is that it's often been used with hyperkinetic movement disorders, particularly in Huntington's disease. When I looked back in the file to see what kind of medications were sort of in effect at the time of 2017, I think you can see from the list here that there's quite a number of anticholinergic ones, as well as the tetrabenazine. And one of the issues, adverse effects, is in fact some issues around swallowing difficulty that was there. She also had a number of PRN medications, which again had some with anticholinergic effects. So my colleague was involved with her at this time and did do what we call a video fluoroscopic swallow study. And it's, I'll show you a couple of examples, but the findings generally were that she had difficulty with this sort of what we call the oral phase, oral manipulation and chewing, but very poor clearance once she actually moved the material into her throat, very poor clearance clearing that material through her throat and resulting in a very high risk for some of that food material entering her airway. There were in fact some episodes of tracheal penetration, and she did have some reduced esophageal clearance. So in order to try and make things safer for her and to address some of the issues she'd been having, my colleague had recommended a liquidized food consistency because that cleared much better through her throat. And this is sort of similar to pourable honey, to give you an idea of what that was. Also a GI consult and a medication review. So what sort of happened between 2017 and 18? Not much was found on the gastroscopy. However, there were some real challenges for Jenny. She was not enjoying the liquidized foods. She didn't like it, pushing it away, experienced weight loss, which was fairly significant for her. And her family became quite concerned about this, and her caregivers, and that she wasn't enjoying eating. At that point, the tetrabenazine had been stopped on the family request, just because they'd noticed she was having some Parkinsonian type of side effects. And I think just to point out that although it had originally been put in as a PRN, at some point it became a scheduled medication. So what happened in 2018, which is when I became involved with her, I repeated the swallow study just so that we could see if there was anything that had changed. We still had the same similar problems with oral manipulation and chewing, a delay in swallow initiation with a little bit of penetration into the top of the airway. And so those were similar findings, and I probably most likely related to her underlying developmental condition. The one really big finding was that there was minimal to mild, just very little residue left in the throat after the swallow. She just seemed to be able to clear things so much better on this swallow study. There was stasis of material still in the upper esophagus with slow clearing, and that was also a similar finding to 2017. So I'm just going to give you an example just to show you a little bit about what a swallow study looks like, and to show you, I'll show a comparison of Jenny's 2017 and 2018. I'm just before that, because some of you may not never have seen one of these. This is sort of what you or I look like when we're having something to eat, our lunch or our dinner, wherever you might be. So I'm going to suggest you watch for the black substance moving. And to give a reference, the esophagus will lie here and the airway lies here. And of course, this is the mouth up here. So chewing phase, you can see the material in the mouth is black looking, and then it clears. And if you notice, there's nothing left, a little final clearing swallow, and everything's gone. It's a very efficient, effective process that we have. So here's the 2017, and this will be on sort of one of the modified textures, sort of that minced, pureed minced texture that that she uses. And I'm just going to show the video here. You can already see there seems to be a lot of black material that lies in the throat area. She's swallowed, and clearly she's not clearing that material very well. And you may have noticed that there's a little bit of black material that had actually gone into the top of her airway there. So move forward to 2018. Again, we're giving her some of that modified food textures. And here we go. She's little bits fallen back, but now she swallows. And I think you can see the big difference there in that little sort of segment is that she was much more effective at clearing the material. And this, again, these are small segments of a larger swallow study that I completed with her. So the big difference that we felt, because all of our other medications seem to be remain the same, was that the scheduled tetrabenazine was stopped by the time we got to 2018. Her oral phase and esophageal phase findings, they were pretty much unchanged, but she had a lot better clearance. And because of that, that tends to reduce the risk of aspiration. And also the difference in terms of her quality of life is, I'll just give you two slide examples. In 2017, and this is a way dysphagia therapists describe different food texture levels. So it's the International Dysphagia Diet Standardization Initiative. And in 2017, she was only able to be on sort of this level right here, which is liquidized. And when we repeated her study with the findings that we found, we have been able to increase that significantly. So what does that mean in terms of real food? This is what she was having to take in 2017. This is where we could expand it over here. So for OTs, function and quality of life is really important. Happier Jenny, she increased her food intake, weight gain, although she still had some vomiting. It wasn't the kind of significant concern that we were seeing from before. So I did a check-in with Jenny, and she's doing well. You'll notice here that there's no tetrabenazine. She's also come off valproic acid, and her glycopyrrolate has moved just to a PRN instead of that. So some of her medications have changed in the time being. And her comment from her mom was that she's just come a long way in terms of some of the behavioral challenges, from very uncontrollable to actually much, much better, and you know, a real celebration of things. So the lessons learned from this, or affirmed in some cases, is that medications can affect swallow function in people with congenital and brain-based disabilities. And so I would really encourage, if you're maybe don't do the swallowing assessment, but you might want to sort of maybe look at some of the other reports in a patient's file and note if they've suddenly developed some swallowing issues, because certainly there can be a correlation. Also, medications prescribed to address one concern, in this case, it was around a lot of the anxiety and the aggression and the behaviors, may have those unintended adverse effects. And I think the challenge always is how are you going to balance this? You know, because challenging behaviors also impact on quality of life. So where do we find the balance, and how do you address that in a really thoughtful way? Review of the medications is an essential part of our OT dysphagia evaluations. We find it's very important, and we always ask that question. And obviously, we're not prescribers or administrators of medication, but we really like to collaborate with the team and have those discussions when we feel that it is, and in our case, particularly with the ability to swallow. So these are some of the references that Bev had mentioned earlier on, just if there's any interest in this particular area. So thank you.
Well, Janice and Bev, thank you very much. Really, really interesting case, and a good example of a team working together to try to figure things out. Also, to remind you that if you're new to the Therapeutics Initiative, you can go to ti.ubc.ca and subscribe for notifications about educational activities, programs such as Portrait for our prescribers. We also have a social media presence on Twitter, and some interesting information on some of the other research and evaluation we're doing that will be posted on our website. So, Bev and Janice, maybe I could start with a question of my own. So this idea of OTs doing a medication review, do you have a hot list of drugs or combinations of drugs, or how do you approach a medication review from an OT perspective or a swallowing perspective?
Beth, do you want me to start that one off?
Sure.
Okay. I think as a rule, as part of our sort of background and history, we always sort of ask for a list of the medications and take a look at them. I think the other thing that's important in that is when we're asking about what is the sort of presenting issue that that's happened with our client base, because many of them have chronic long-term issues with swallowing problems. If something's changed in that, one of the things we'll always ask is, well, is there anything changed in the medications or the medical history that might have precipitated this in here? So we're always looking for those kinds of things.
Oh,
and
I understand.
even dosage changes, like, oh, they increased a medication or something happened there. So we're trying to sort of put it into the whole picture of why are we seeing some of the things that we are. And certainly I think, and Bev, you might want to comment on this about the alertness, since you have had a couple of those incidents.
Yeah, absolutely. So certainly, if drowsiness or just general sort of detachment from not even engaging with their food is part of their profile, that will certainly give us a big clue about sort of digging deeply about their medications. One of the things, a couple of other things that I found helpful as well, is to ask about the time of day of administration. So sometimes we've had issues where the caregiver says, oh, they're too drowsy to eat. And then when I ask, well, what time are they're most alert during the day? What's the best time to feed them? they often, when you look at the timing of their medications, it's often right before that next dose of very sedating medications. So I ask the caregivers to really pay attention to alertness with respect to the time of day. And then the other question that we're also interested in is, how are those medications actually administered to the person? So some clients may be taking their medications with water, others whole in puree or crushed in puree. And so sometimes when the caregivers are mixing those crushed medications with something like Fruit Lax, for example, it may become very viscous and sticky, and they're not recognizing that they've deviated from the recommended texture guidelines, and they're giving something that's too gooey and sticky to be swallowed easily.
Okay, that's very useful. Thank you. We have three other questions. One is, the tetrabenazine, was that initiated by the family, or was the primary prescriber the one that started that?
That
Do you
was,
recall?
I think, from what I understand, from the family, because I didn't know where it had come from either. And this was when she was still in her teens. It was brought forward, I think, that one of the family members had seen something on, I guess, on TV about it, brought it forward. I think it was a neurologist, and suggested it as a trial, I guess, because they were really trying to sort of get this young lady out into community and being able to live there. And so it was prescribed at that point. As I say, I sort of, as I delved into it, I think the thing that struck me is that as a PRN, and I don't know how often it was given, but at some point it became a scheduled medication. And it seemed like that around that time was when we began to see a lot of these issues where her swallow became worse and she was really struggling more. So I understand from Dr. Perry, it's seems like it's an old medication and not necessarily one that's perhaps prescribed as much anymore. I'm not sure.
Okay, thank you. The next question is about opioids, and are they on your sort of watch list for causing problems such as this? Or on your list in general for other issues that you encounter with your patients?
I don't know if we run into opioids quite as much from our group. I think anti-epileptic and anti-seizure meds are probably the most common things with our population group. A lot of them have dual diagnoses. So, you know, with the underlying. So I don't know if I've come up with that many of the opioids particularly. Would you agree, Beth?
Yeah, so mostly we're seeing pain managed just with acetaminophen. And perhaps because
on a related note, if I could ask, so go ahead.
Oh, I was going to say probably because sometimes their pain isn't being well recognized and maybe coming out as behavior and no one's putting two and two together.
Got it. Okay. So in an early slide, Bev, you had the anticholinergic burden. Can you just reiterate, like, how do you figure that out, and what role does that play? That's a clue to something. What is it a clue for?
Yeah, so I use the anticholinergic burden calculator, which is readily available online. And what I use it for is kind of in those two scenarios where I had case 2 and case 13. So when I look at the anticholinergic burden score and which of the medications are sort of the greatest culprits in that calculator, that helps me communicate back to the prescriber about where I think some of those other symptoms that the patient is presenting with might be attributed to their medications.
Okay, that's great. Thank you for that. And then one question, what other clinical professionals support you as you look at these scenarios, especially with possible medication risks and benefits assessments, and then the subsequent adjustments you might make?
Okay. Well, certainly we work in a team, and we're often working with dietitians and nurses, as well as, although a physician may not necessarily sort of be there in person, but we often work through the family and the caregivers to go back and speak with the physicians, or we may send a letter and forward a letter if there were issues or concerns that we expressed around that. There's often a large sort of a broader team of people that may be involved, neurologists and other people as well. But the sort of core community team is often the nurse and the pharmacist if there's questions about that, as well as we work quite closely with the dietitians who have some good background in the nutrition interactions with medications as well.
I've also, in one of the cases in that 32-person cohort, worked quite closely with a physiotherapist who could also provide some additional information about the physical changes that she noticed in the patient that coincided around the time of a particular medication change that also coincided with the swallowing problem.
Yeah, it's so interesting how everyone, like a fresh set of eyes from a different perspective, can add light to what the source of the problem is. So that's great. I'm just looking at the time, and it looks like our time is wrapped up. Again, Bev and Janice, thank you so much for an excellent presentation. Tom, I'll turn it over to you.
Okay, good morning, everyone. My name is Kelly, Dr. Soros. I'm an emergency and family physician. I'm on Gitxsan territory working. I'm grateful for that right now. Co-presenting with my father, Ross Soros, who's also here and is going to turn his camera on, about his story with just the importance of listening to patients with severe chronic pain and the stigmatization that goes along with opiates and non-cancer chronic pain, and kind of the importance of his journey of deprescribing, or kind of lack thereof. So this is my dad in 2019 when this whole journey of deprescribing started. Ross has a history of a really rare metabolic genetic neuropathy called H10-1. He actually had symptoms since he was 38 years old. However, genetic testing wasn't really available until 2019. In summary, along with some autonomic stuff, he has severe neuropathic pain from his elbows, hands, knees to his feet without any external sensation. So he gets the neuropathic complications such as chronic wounds and such. For many years, he's been attached to the St. Paul's Pain Clinic, and the most helpful stuff was self-hypnosis with the psychiatrist there, who has retired, but a new one's kind of taking over and getting up to speed. He also worked with their pain clinician for many years, which we're going to dive into in a bit. And then he actually, because he was on opiates for so long, has had many pain contact or addiction medicine consults with no substance use disorder. I won't list them all, but those are all the medications that he has either tried or is currently on. They're your kind of regular chronic pain stuff. And all of these caused a lot of problems and weren't giving him significant relief. And I'll get you to go to the next slide. And I just want to paint a clinical picture of what happened to my dad, Ross, from 2016 to 2019. We had a really long-standing relationship with his pain clinician for over a decade. And, he's never going to be out of pain, but we had a therapeutic relationship until 2016. The College of Physicians and Surgeons of BC released a new opioid standard that really limited the ability of physicians to prescribe opiates to non-cancer pain patients. They made a morphine equivalent cap. There were physicians getting audited. It required such a high level of documentation that there were fines going out, and it created a lot of fear in physicians. And this is when my dad's therapeutic relationship really eroded with his doctor. And it forced Ross, who was on hydromorphone and sufentanol, which was working okay, to transition off that to Suboxone and ketamine. And this was really harmful to Ross. So we were initially told that if it didn't work, we would be able to go back on what had been working. And we were told that the Suboxone had such great evidence for neuropathic pain, it was going to be life-changing, and faced a lot of stigma when I questioned that evidence and didn't think it was right. And, it didn't work. And he was in a lot worse pain. He was forced to withdraw from opiates at home alone with no support, which is awful. The ketamine ended up causing him to be hospitalized for mania. His GGT went through the roof in the thousands, which led to unnecessary ultrasounds and liver biopsies. He also, at that time, developed AFib and has had 2 ablations, and he's now on lifeline anticoagulant. And it was to the point that he had such fear, anxiety for every appointment that his physical and mental health was so severe. He was stigmatized, he was depressed, his pain was not controlled. And to put into context, I graduated medical school in 2019, and I deferred my residency for a year because he needed that level of advocacy. And the worst thing was that Ross knew what worked. He knew opiates such as hydromorphone and sufentanil worked. He had been on these for 25 years, and because we were not able to have a good relationship, it was so hopeless. Like, no one was listening, and we were forced to be put on all these drugs. So next slide. This is what he was on in 2019. So he was on the left, you can see there's 5 pain medications, and it felt like every time something was started and it wasn't working, we either upped the dose or we added something else. And gabapentin was up to a really high dose. He felt that he was falling. He was cognitively impaired. Lamotrigine was added. It wasn't helping. Same thing was the thinking. Oxcarbazepine and ketamine, all the same. And we were just told, oh, we're going to go up in dose, instead of, taking it off and trying something new and being pretty thoughtful with things. And it was to the point that he was almost, not able to live independently. Next slide, please. So we were really questioned with what should we do? At that time, should we stay with the current prescriber? Are things going to be worse if we switch? Are we able to get any opiates if we switch? We advocated for his family doctor to take over prescribing because the therapeutic relationship was so strained. He was really uncomfortable because of the guidelines, and he actually prescribed us to Dr. Perry. And we're really happy with that, but there is a fear that things aren't going to get worse. Luckily, we did see Dr. Perry, and we'll go to the next slide. And this is just a video of how he presented on his first visit.
You've got quite severe peripheral neuropathy, and it's a genetic condition, is it?
Yep.
Do you know the name of the condition?
Yep. It's hereditary, sensory, autonomic neuropathy type 1.
I'm just curious if you can tell me which drugs you're taking now that act on your brain.
The gabapentin, the lamotrigine, and I'm not too sure about the ketamine.
And are you also taking hydromorphone?
Yes, I take 8 milligrams 12 times a day, so that's
48.
48. Yeah, that's what 48 milligrams a day.
Do you feel clear-headed now?
Fairly. I'm when I'm trying to get out something, I'm a little confused.
Get out as to explain something?
Yeah.
What about your balance?
I'm stumbling. I'm out, but as balance goes, I'm always, because of some part of the neuropathy, a little off balance.
I wonder if I could get you to put out your hands and close your eyes. Just hold them there as long as you can.
These were our concerns. Like, what he was on wasn't working. It was causing him to fall, and his cognition was intact. We knew what would work. We had fears of other medications because we tried them in the past. But really what we wanted was a therapeutic relationship that respected Ross's patient expertise and would give us, the respect that, he deserves in order to try something new in a safe way and listen to him. I'm going to pass it over to Dr. Perry, who's going to talk a little bit about his initial approach when he met Ross.
Yeah, when I met, I'm sorry, I didn't give Kelly and Ross the introduction they deserved. As you can see, Kelly's an extremely thoughtful young physician working in challenging jobs, including a difficult downtown emergency room and currently in northern BC in an underserviced community. And her dad's a very courageous guy that you'll see in a bit what he's been dealing with. But what struck me when I met them, aside from the fact that it's a very nice family, was that he was really out of it. And perhaps it wasn't immediately visible in the first video, but you noticed that he had marked asterisks and a lot of myoclonic jerking, this kind of unexpected jerks. And the number of drugs to me was greater than the number of neurons in the prescribing doctor's head, perhaps, because it becomes completely impossible to know what might be going on with that many drugs, given how hard it is to know with any one of them. I also thought, knowing randomized controlled trial evidence about such drugs for pain, the chance that any one of them was useful was probably exceedingly low compared with the chance of toxicity. And the goal for me was that he needs the best possible analgesia and a clear head, because it was important to him to be able to continue driving. So what I thought initially was gabapentin is so unlikely to be helpful even for neuropathic pain, so likely to impair his balance and intellect, that I wanted it gone. And the same thing for lamotrigine, he couldn't identify any benefit from it. With oxcarbazepine, he was being encouraged to increase the dose, which was, from my point of view, completely irrational. And I just challenged him, either taper it rapidly over a few days or stop it cold if you want, and gave him my email and telephone number. And ketamine, he had a somewhat higher opinion of it, but it was clearly impairing his thinking and causing anxiety and high blood pressure. And he preferred sufentanil. So even though a potent opioid was discouraged at that time, there was no question that if he had been able to prescribe for himself, that's what he would have chosen, and that there was no element of addiction. The same with hydromorphone. I wondered whether methadone might work better, as it sometimes seems to do. It would certainly save money for whoever's paying for this. But he was afraid of methadone because of oversedation, and the solution to that was to get rid of a lot of junk. So I gave him very clear written recommendations. It was helpful that his daughter was a nurse and physician, and he got on with it promptly. And after the first step, the goal was to simplify as much as possible. In effect, a complete challenge to the idea of quote unquote multimodal analgesia, which to my knowledge has very little supportive evidence, if any. And at about not quite 5 months after the first visit, we had a number of contacts in between, both in person and email and telephone. He was now on hydromorphone at the same original dose. He was on ketamine as needed. I'm sorry, he had been switched to methadone, at the right side of this panel, and sufentanil only, and all the other drugs were gone. So you'll see in a second what he looked like then. We've made some changes. How are you feeling now?
I'm feeling pretty good, yeah.
Is there any difference to your thinking?
Yeah, quite a bit better, and don't seem to be as drowsy.
What about your speech?
It's a lot better. I can get words out a lot easier.
And could I get you to hold your hands up? Pretty steady, I think, compared to when I first met you. What are you taking now?
I've taken methadone throughout the day, up to 10 times, and sufentanil up to 6 times a day, 50 microgram.
So gabapentin and ketamine are gone now?
Yes.
And oxcarbazepine and lamotrigine?
Yeah.
And you don't miss them?
No.
So Kelly's, we're going to go back to Kelly at this point, but hopefully it was obvious how much he had improved intellectually, and he now had a simple regime. The sufentanil is expensive, but he had a benefit plan that covers it.
Yeah, 4 years later, we're almost on the same stuff. We've come down on the methadone just because he added some antibiotics that were causing some interactions, and then quite significantly up on the sufentanil. And I bet a lot of people haven't seen sufentanil used in this way often. And I've never actually seen somebody else, but Ross is very clear that for his pain with the spikes and neuropathic pain, sufentanil is very helpful under the tongue. It takes the spikes away, and he has no sedation or cognition side effects. And we've trialed it many times, and it really works for him. And particularly to the methadone, he was so scared to start it because he had tried 3 times before, but he was always on all the other junk, the gabapentin and everything. And when we tried it without all the other stuff, it gives him the best analgesia. He's still living independently. We go fishing once a year. We have vacation place. He's with a psychiatrist who's doing hypnosis. He's driving. We're renovating his house. And we're getting prescribing by his family doctor, which requires some advocacy, but it is having this plan, it's much better. So I'm just going to show you a video of Ross today that we took last month.
Come on, Tink, bring me the purse. No, bring me the purse. Come on, bring me the purse. Good girl, Tink. Place. Up. Good girl. Come on, get down. Come on. Okay, open the cage. Get in. Open. Get in. Close the door. Good girl, Tink. Here you go. Good dog. Whoops, drop my phone. Get my phone, Tink. Come on, get my phone. Good girl. That's a good doggy. Okay.
Tink's probably the best medicine. But I just want to open it up to my dad. Dad, I don't know if can you talk, about just what it was like to have the stigma of being, on opiates and how that affected you physically and emotionally?
Well, it gave me I was kind of depressed, and it gave me a lot of anxiety. It was just, there's just like a lot of stigma about it, and it makes you feel like, especially when you're dealing with pain, and if you don't take it, you can't. I don't know. I don't think you can live with that much pain, and it works good for the pain. And it's just too bad there's so much stigma around it. When you have chronic pain, it's not like you've been in an accident and you're gonna be over it. It's you're gonna have it, as far as I can see, for the rest of my life. So it's.
And how did you feel, Dad, like when you were on all those medications and they kept adding the medications? Did you find that helpful, or, this is a deep prescribing webinar?
I kept feeling I was getting, in my mind wise, worse and worse and worse. And if they weren't working for the pain, but it seems like they just would leave what they've already prescribed and then add to it, and wouldn't take anything away.
And then last thing, just like we've talked a lot about your anxiety before, and even now sometimes with your family doctor. What is it like before you go into an appointment with a doctor when you need an opiate prescription?
It gets fairly high, the anxiety, because I don't see the questions and wanting me to take drug tests for not only the ones I'm on, but all drugs and everything. So it's very, very a lot of anxiety over being treated like an addict.
Dad, and I just, like, from myself, from a physician point of view, I've learned a lot from you, and especially, how much advocacy it takes for families. And I have a lot of respect for that, because I know we had to, really get our family to help. And then the fact that, we always came in knowing what we wanted, and I try to do that with my patients and like listen to them, because it honestly makes my job a lot easier when they can help with what's worked before. And then just a little plug, we find the videos that Dr. Perry did really beneficial, not only for teaching, but to see how far he'd come and to give us like an objective stance on that. So that's all we have. Happy to hear some questions.
What a wonderful, heartwarming story, and a great outcome. So thank you so much for sharing. One question I have is for both you and Tom Kelly. How do you think that other prescribers, especially the family doctor, needs to be involved and supported? Like what messages would you have for others out there?
I personally, I'm a family doc as well. Like when you get a report from a specialist, a pain physician, it kind of is a good documentation of what's going on, right? But you are the person that sees that person, that knows them, and they're going to need you to keep prescribing things that work for them. So when you're on opiates, it's really medicalizing. Like we can't travel, I'm up here in the north. I asked my dad to come, but he couldn't come because it's in the middle of his prescription, cycle.
Sorry, I was, there was a little bit of noise in the background. I was trying to quiet. Aaron, do you want me to respond to one of those?
Yeah, if you wouldn't mind, Tom, because I'm getting only
Yeah, I
parts of the
see Dr.
conversation.
Chris Roche, geriatrician, asked how best to communicate with other people involved, including the family doctor. And I'm essentially retired now from clinical medicine, but my approach was always to do a very careful, detailed consultation, document the thinking about drugs carefully one by one, advantages, disadvantages perceived by the patient, any evidence I could bring to bear on it from when relevant from clinical trials, and then send that to everybody involved, all prescribers or anybody else I could identify. Usually one wouldn't have been able to identify the occupational therapists unless it was in hospital where they had access to a chart. But ideally it would be to anybody who's bound by confidentiality. And I think then obviously the old-fashioned technique of the family doctor communicating and vice versa by telephone is probably ideal. It's a big challenge in the fragmented care system now, but I think one thing I learned over time is that often those requesting a consultation may or may not have specified, we really want you to act definitively, but it's better to do it and take some risks. And with that goes accountability, including being available to the patient by telephone or email or some way that if they get into trouble, they have an out. Aaron, I see one other from Karen regarding why I was so down on gabapentin or pregabalin. The easiest way to deal with that is to refer you to any of the 3 therapeutics letters at our website that we've published on gabapentin. The experimental evidence is that if those drugs are helpful, they're helpful almost immediately. That means even within hours of taking the first dose, within 2-3 hours. And there's very little dose response. There's obviously some because 0 milligrams does nothing, and 900 will make many people feel off balance or sedated, but there's not much dose response. And the likelihood of significant benefit is definitely no more than 1 in 6 people. I think it's a lot less than that from my experience. I've almost never had a patient regret when I suggested stopping gabapentin or pregabalin, which tells me a lot. So while you're thinking there, Karen asked, what would the alternative be to gabapentin or pregabalin for, let's say, quote unquote, neuropathic pain? Well, this is an unpopular idea and it's not well supported by clinical trials, but I think Ross is an example where opioids actually do work a lot better. And my clinical experience dealing with, I guess, hundreds of people over about 20 years is that if I were in his position, I would hope to be offered an opioid. And perhaps methadone works better than others. It's very inexpensive, or should be. It's less expensive in bulk than flour or sugar or salt. So at a global level, for people in other countries who are participating today, methadone is worth learning about if it's legal in your country.
Tom and Kelly, I have a question. So one of the things in this story was they would start a medication and it didn't seem to work, and so they added on and that didn't work, and then they added another. How can that problem be fixed? Like if you were to give some guidance to prescribers about reasonably short therapeutic trials, or how do we fix that problem?
I mean, drugs are typically assessed at 2 weeks, 4 weeks, 8 weeks, sometimes longer. But there's a practical reason for that. The clinical trial is expensive and the company wants to do it in the most efficient way. And they don't want people to only take it for a day and stop. Otherwise, they'd never make any money. They want people to take drugs for a long time. But in reality, they work very fast. And that's probably true for virtually everything except drugs used for prevention. So my practice would be, if I were still prescribing much, would be, try perhaps a week as the maximum of any drug. And I think adding more drugs and then adding doses, it's just completely irrational. It's we wouldn't do that in cooking. Aaron and I learned that from a cook once when we hosted a deprescribing session. I said, does the soup or the food get better as you add more and more ingredients? And his answer was very simple. No, the best food is the simplest food. I'm not sure who else is there. Do you, I
There's
can
a
try to
question,
answer
Tom,
two more.
about Suboxone as an alternative to methadone.
Well, Suboxone, it's much more expensive to start with, and it's got an antagonist built into it. So if you're looking for opioid analgesia per se, it's not, maybe it's theoretically safer, but as you can see, Ross is perfectly alert, and he was in more danger when he was getting too many sedative drugs that were non-opioids. Once he was on opioids alone, he was tolerant to them. It's sort of a mystery to me if a person becomes so tolerant, how come the drug keeps working? But that's true for money. People can get very tolerant to money, and money still works.
And
But
another question about fentanyl patch.
I don't think so, because the advantage of a fentanyl patch is continuous 24-hour delivery. And that would add nothing to having frequent hydromorphone or methadone. So whereas with the sufentanil, the presumed advantage is he gets, when he gets a severe bout of pain, he gets a hit from the sufentanil very rapidly. It's not quite as rapid as one would hope, but it's probably within 15 minutes or so.
Yeah.
Tell us, Ross, how fast, if you take sufentanil, how fast do you feel relief?
Within 10 minutes, I'd say it starts to, yeah.
And how long do you think it lasts?
That's really hard to answer, because that the severe pain is gone for a long time, but I don't think it lasts very long. Like you might be only talking about 15 minutes, maybe 15 minutes, maybe less, but what it did, it lasts for a lot longer, like for hours, a couple hours.
But if as a shorter elimination half-life drug, if you don't use it too often and it wears off, then hopefully one becomes less tolerant to it over time.
Mm-hmm.
There's one other question about the College of Physicians rules in BC and perhaps in other Canadian jurisdictions. They have been loosened up in reality, so that the deputy registrar in charge of such patients and issues would, I think, approve fully of the treatment that Ross is getting now. It's because he's alert, he's highly functional, and it's safe. So I think the rule was modified, and people do not need to be quite as afraid as they were 7 or even 5 years ago. Aaron or Chipper, do you see any other questions that we haven't dealt with? Someone wants to know about cannabis. Did you try that, Ross, or?
Well, I've
Ross
tried
did try it.
It didn't work, and actually it caused me some when I took what was that one,
Navalone.
Navalone, that was quite caused a lot of anxiety, and actually sort of made me crazy a bit.
Yeah, my experience was cannabis very disappointing. I never met a patient who, given the choice, if you can go to a desert island with your morphine or your cannabis, which one will you choose? They always chose the opioid. Pei Liam is asking, are family doctors still audited and sent letters about opioid prescriptions? I presume so. I don't know the answer to that, but I think it might be a little bit more cautiously so than was the case 6, 7, 10 years ago. I hope so. I think we've run out of time, Aaron. Maybe I can just thank Kelly and Ross again and Ross in particular, for sharing your story, being willing to allow that to be public and posted on the internet. I know Mr. Soros has thought about it carefully and felt that the benefit to other people exceeded any loss of privacy. And everyone can see what a nice guy you are, Ross.
Thank you. And thanks
Are
a
you
lot. And
inviting any of us to go fishing with you next year?
sure. And Dr. Perry, I got to thank you for the help that you gave me, because I don't know where I'd be at if I didn't get all that straightened around. So that's good.
And Aaron, I'm just going to take one last chance to beg the audience to consider submitting cases. Our next session will be in March 2024. We haven't decided when yet, but we haven't got any people applying yet. So wherever you are in the world, this includes people outside of Canada, if you might be interested to present a case, please get in touch with me at tom.perry@ubc.ca. And we thank you all for attending.